So today's class will be on applied anatomy of brain, and we're supposed to cover spinal cord, but it will be a very huge task. So we'll split the class into two classes. This class will concentrate on brain and the brainstem, along with some interactive cases. Also, we'll start. And uh, anybody, are you able to listen to me? Just say yes.
Yes, sir.
Am I audible?
Yes, sir.
Am I audible?
Yes, sir. Yes.
Some of you can tell.
Yes, sir. We can hear you.
Akhilesh Agrawal, am I audible?
Yes, sir. Yes.
Hello. Am I audible? Somebody will tell. Okay, thank you. Thank you. Right then, that's nice. So we can carry on with our conversation on applied anatomy of brain and brainstem. So we'll have some interactive case discussions in between. So as people are joining, it's time for us just to go through the blood supply of the brain, and what we see is that there is an anterior circulation, there is a posterior circulation, and brain requires a lot of blood and constant supply because it requires glucose and oxygen at a very fast rate, and its stores doesn't last long once the blood vessel is occluded, and you have the anterior cerebral artery, middle cerebral artery, posterior cerebral artery, the basilar artery, that is called vertebrobasilar system, and the carotid system supplying the blood to the brain. And these are the various branches of ventral carotid, ophthalmic, anterocerebral, MCA, posterior communicating, and anterior choroidal. And the vertebral has meningeal, anterspinal, posterior spinal, posterior inferior cerebral artery, and the medullary branches. The basilar has got anterior inferior cerebral artery, labyrinthine, pontine, superior cerebellar, and postcerebral. So these are all before we start on the real brain picture. Before the people join, I just started the class by saying that brain is supplied by major blood vessels. There's got large vessels and also small vessels. Any vessel can rupture and cause intracerebral hemorrhage. Any vessel can get occluded, also cause ischemic damage to the brain. There are specific areas of middle cerebral artery, anterior cerebral artery, and posterior cerebral artery, which will supply the brain, and the map which is depicted will tell you which areas will get damaged if the blood supply is ceased to that. The key physiology brain is made up of trillions of neurons, and they are fully dependent on cerebral blood flow. The constant supply of oxygen and glucose is brought through the blood, and the perfusion pressure should be optimal. So, if what happens is next, yeah, right. Cerebral blood flow is about 45 to 50 ml per 100 grams per minute. If it drops to 20 ml per 100 grams per minute, then the physiological electrical function of the cells begins to fade or fall. So normal cerebral perfusion pressure is about 80, which is between the mean arterial pressure minus ICP. And if cerebral perfusion pressure, which is 80, falls below 50, then ischemia and reduced electrical activity sets in. The demands you see, oxygen consumption is about 3.5 ml per 100 grams per minute. And if blood supply to any area is blocked, it lasts only 10 seconds. So that means constant supply of oxygen required. The glucose utilization is 5 milligrams per 100 grams per minute, and it maximum lasts for 2 minutes if blood supply is cut off. So these are the huge demands on the cerebral neurons, by neurons on the blood. Now you can understand why it's important, because the neural circuitry loss in a large vessel, acute ischemic stroke, per stroke, 1.2 billion neurons are lost, 8.3 trillion synapses are lost, and the individual age by 36 years, because 4,470 miles of myelinated fibers are lost. If you look at the second, 32,000 neurons are lost if blood supply is stopped, and 230 million synapses are lost, and he ages by 8.7 hours per second. So every minute if stroke is untreated, the average patient loses about 1.9 million neurons, 13.8 billion synapses, and 12 kilometers of axonal fibers. Each hour in which stroke treatment fails to occur, the brain loses as many neurons as does in almost 3.6 years of normal aging process. So with this brief introduction and the stress on the brain function, the oxygen glucose requirements, the blood supply requirements, and identification of damage to brain. So we go ahead with the applied anatomy aspects of the brain, and the big picture of the brain and its functions can be learned by looking at the big picture. The left side of the brain is concentrating on language and praxis. The right side is spatial representation and prosody of what we talk. So that's the left side, and the right and left. You see, there is also an anterior and a posterior. This thing, the anterior part that is in front of the central sulcus is action oriented. The posterior part of the brain, that is post-central gyrus and beyond, is perception related functions. So this is a huge picture. The brain, which has got frontal lobes, temporal lobes, parietal lobes, occipital lobes, is earlier thought to have a localized functions. But now as you see, the circuits have changed this concept. So there is a dorsal stream of connections which mediate where is the problem type, and the ventral stream is what is the problem. So what question is answered by the ventral connections, and where question is answered by the dorsal. So this is a broad idea, and with this big picture, how the brain is maintaining arousal and awareness, and the frontal syndromes, because they are important, because the frontal syndromes, the frontal lobe in primates is present only with humans. So its functions are very important for us to understand, and how brain does deal with memory, language, and a cortical visual processing, and the spatial attention. In front of our eyes, we have visual fields and the motor systems and somatosensory processing. This is the brief which we are going to talk about the brain. So let's start with arousal and the awareness. The arousal means a man can go and level of sensorium can dip and become comatose. And what is a system that is keeping us awake from midbrain upwards, bottom up, ascending reticular activating system, which is present a group of neurons, a large number of neurons, and their axons and tracts which are going up into the cortex. They are getting the sensory inputs from the periphery and keeping us awake. This is the bottom up ascending reticular activating system. And this another one is a top-down frontoparietal and limbic attention modulation system, which mediates the various areas of the brain function through connections, networking. So this is a lateral frontal association cortex, lateral parietal association cortex, anterior cingulate and medial frontal cortices, and upper brainstem, thalamus, hypothalamus, basal forebrain, precuneus, posterior cingulate, and retrosplenial cortices. Now, I just wanted to ask, what is association cortex? Association cortex is vast assembly of neurons that are present in cerebral cortex in all the lobes apart from the primary sensory and motor areas. So these are the areas where memories are stored, right? So these are the networks which I'll just show you the networks, but I will not talk much about it. That means each area of the brain is connected to other area. If a damage is there here, the result may be perceived in other areas also. So this is a perisylvian language network, which we will discuss in detail on the language network. And you see that the Wernicke's area is connected to the Broca's area with arcuate fasciculus. And the limbic or retentive memory network, which is mediated by hippocampus, parahippocampal region, and you can see this network, which has fornix and mammillary bodies and amygdala, will come back next in the subsequent. The parieto-frontal spatial cognition network mediates. So brain areas are interconnected with a lot of networks, and a prefrontal attention and behavior network. And the attention is mediated in the frontal lobes, and its connections with limbic system and the parietal cortex and occipital cortex will make it enable to do this function. The occipitotemporal network, face and object recognition, which is coming from striate cortex, and so this is another important network. So we normally are bombarded by sensory stimuli that we filter based on salience, what is important for us. So we get the sensory stimuli from auditory, from the visual, from the somatosensory, so various from internal organs also. But we are not at all paying attention to all of them, but we pay attention only to things which we want to pay attention to. That is awareness. And the eye is, if you are asked to look at this group of individuals who and identify the ball, you or I will be concentrating only on this eye, but it will not be concentrating on the ball, on the man who is here and who did a dance and he disappeared. But you are only counting the ball, that is a basketball. So, but if you ask them to look at this, any person, then you will shift your attention. So that attention shifting, the cocktail party effect. Whenever you are in a party, lot of voices are heard. But suppose somebody say, "Did you hear what SP did?" Then suddenly you will now come into attention. So this type of behavior is mediated in the brain through the attention circuits. So the arousal and awareness can be affected whenever the bottom and top network of reticular activating system is disturbed, or the top to bottom frontoparietal and limbic attention network modulation is affected by various lesions which are seen here. If you have a hypoglycemia, it attacks multiple synapses and cause loss of consciousness in the cerebral cortex. Similarly, hypoxia. So like that, if multiple synaptic dysfunction is present, then you can have loss of consciousness. Otherwise, in brain, it is attention problem or awareness problems that come in the cortical area. In the brainstem area, it is almost arousal disturbance. For a person to lose consciousness because of the cortical damage, it has to be very extensive, more than two-thirds. So that brings us to the most charming of the brain functions and what we are here today because of the frontal lobes. Frontal lobes, which are the what you call phylogenetically, they are the latest acquisitions in the evolution, and the humans are blessed to have them. And if the dorsolateral part is concerned with your organizational skills, your planning, etc. And if there is a disturbance in that, then you develop perseveration. That means you go on doing same thing again and again, saying same thing again and again without any check, and you become stimulus bound. You don't filter anything. Whatever comes in front of you, you start picking up utilization, behavior, and the attention becomes short, that is impaired digit span. So that is the dorsolateral frontal lobe. And what is the mesial frontal lobe? This is what you are active today. You are learning, your energy, everything is mediated in the mesial frontal lobe. And if there is a damage in that, you will become akinetic and mute. So this is the mesial frontal lobe function, which one should broadly understand this. And third is orbitofrontal, the Flias gauge incident, where a iron rod has pierced from orbit into the basic frontal region. After that, that individual became impulsive, emotionally labile, with inappropriate jocularity and hypersexuality. That means the moral turpitude, the values, the, the discipline in the body, everything is controlled in the orbitofrontal region. So see, the three surfaces and the extensive frontal lobes are very important in humans, and that's what you should remember. So as far as memory is concerned, the auditory, the visual stimuli, they are entering our bodies, that input. There are sensory memory, that is milliseconds, and it is captured by the brain. If your attention is intact, that means ability to hold the information across an undistracted delay. So if any delay, if any distraction is there, you lose this. So you can remember a span of about 7 plus or minus 2 items, numbers, and in this memory span, and you can dial a telephone or you can make a brief conversation. This is the short-term memory, which is localized in the prefrontal cortex. And after that, by rehearsals, it becomes a long-term memory, which will be in the hippocampus and pepper circuit mediated, and but it is not lost by distraction, unlike the short-term memory. This long-term memory or recent memory is the other word for it. It is lost in Alzheimer's disease, and anterograde learning depends on this. The remote memory, and that means the long-term memory or the recent memory after consolidation becomes remote memory after more than 6 months, and you have the memory of the events many months ago. You develop semantic knowledge about the facts of the world, and you develop procedural skills, and you also, and this is distributed in the cortex, and its retrieval is not dependent on hippocampus. That's the most important. So some of the important aspects of memory we touched, that is the short-term memory, long-term memory, and remote memory. So the one thing I wanted to stress is procedural memory. If you, a man with a problem in the temporal lobes, still can have procedural memory. You make him learn this drawing, which is a bit complicated. He has to fill up this with ink looking into the mirror. So he will develop this skill. First day, he will make many mistakes. When you ask him to do next day, he didn't know that he has done this, but he will commit less mistakes, and learn faster. Similarly, by third, that means this procedural memory is developing and which doesn't require the hippocampus formation. So this is very useful in our Alzheimer's disease individuals where they can be trained. You know swimming, you know cycling, but you don't know how and what areas you're developing. Without knowing it, you can still do it. That's the procedural memory. The Pepper circuit, which is displayed here, the hippocampus, the entorhinal cortex, the fornix, and the mammillary bodies, the mammillothalamic tract, the anterior nucleus of thalamus and cingulate gyrus. This circuit reverberates and vibrates and consolidates the memory. So that brings us to the language part of the brain. The Heshen's gyrus is the primary auditory cortex where whatever I am talking, you are hearing, and that is again processed in the Wernicke's area, which is present in the superior temporal gyrus, and here it is comprehension. Comprehension is very important here because auditory and language areas, they are connected, and what happens is here the angular gyrus, it links what are stored written words and images in the hippocampus and the three is arcuate fascicular. So you should know that the Heschel's gyrus, this is the, if there is a disturbance in this circuit and patients will develop language disturbances and they are called global aphasia, Broca's aphasia, transcortical motor aphasia, Wernicke's aphasia, transcortical sensory, transcortical mixed and conduction aphasia. And conduction aphasia, that arcuate fasciculus disruption will have problems in the repetition, but the comprehension and fluency are intact. If you look at the global, all three components are damaged because of the large dominant hemisphere problem, and the Broca's aphasia characteristically is fluency is decreased, repetition is impaired, but comprehension is very well preserved. It is an inferior frontal gyrus. Transcortical motor means the surrounding area of the Broca's is disconnected from the Broca's area, that is mesial frontal, where comprehension is preserved and repetition is also preserved. The Wernicke's area, the fluency is preserved, but comprehension is gone. As I showed you in the previous diagram, repetition is also impaired. Similarly, transcortical sensory, like a sensory motor, the repetition is preserved, but fluency is also preserved here and comprehension is impaired. So this is a temporoparietal junction. All around the Wernicke's area, disconnection happens with the surrounding areas. Transcortical mixed is both transcortical areas. So this is a language disturbances or aphasias, but it takes about 1 to 2 months for an aphasia syndrome to have a reliable localizing value. That brings us to the optic bundles. So this is optic chiasm, the optic nerve, the optic tract, which is getting it, and those who are in nowadays reading ophthalmology, it will be interesting. The optic tract and optic radiations are bringing this to the striate cortex. And why striate cortex? I'll show you in the next slide. This is a Mayer's loop, which is connecting in front of the temporal horn and going back towards the occipital cortex. So the visual cortex, the occipital lobe, this is the coronal section, and this area, if you enlarge and see, there's a stripe of Jenneri, lot of afferent input comes to occipital cortex, and this is a maximum in the body. So a lot of visual information is is sent to occipital lobe for processing myelinated inputs to layer 4 of the visual cortex, and this stripe of Jenneri, that's why it's called striate cortex, which is visible as a white line. And a retinotopic map will start picturizing now in the striate cortex. Occipital cortex is meant for visual processing, and this is the gyrus and this is the sulcus. And next photograph you see, This is the field, eye field. And you see the central vision. The central vision in the eye field is represented maximally in the occipital cortex and the striate cortex. If you look at this, the maximum, this is only at 10 degrees and it is represented almost more than half in the cortex. That means the acuity of vision, the central vision, which is important for human beings, takes a lot of place in the occipital cortex, and it has got a dual blood supply. So central vision is not lost in occipital cortical infarctions. And as you see, the next field of vision occupies this much, and next is occupying only this much, and there is a small area which is a unilateral ipsilateral. This is called the monoocular crescent, and if there is a monoocular crescent, that means it is a cortical infarction. And similarly, the vertical meridian is represented here, and the horizontal meridian is represented, and the lower vertical meridian is represented in the superior portion of this striate cortex, and this is the horizontal meridian, which is in the depth of the sulcus. So retina topic maps to be kept in mind when you are assessing the visual function. And bitemporal hemianopia in the visual fields, both the temporal fields are affected in optic chiasma or meningioma supra, also the chiasmal region, and this is the pituitary gland region where you can get bitemporal hemianopia. And the temporal lobe tumor here is causing homonymous bitemporal superior quadrantanopia. That means visual field defect is homonymous, means retrochiasmal. And here you are in the binasal homonymous superior quadrantanopia because of the inferior occipital infarction here. And you see the occipital stroke is the macular region is macular sparing infarct, the visual field defect. The macula is spared, as I said, because the representation is more. So that brings us to the cortical visual systems. The dorsal Ware pathway and the ventral Watt pathway is seen here. And here the facial processing takes place, and that's where the defects in this area will give rise to prosopagnosia. You see the tumor, the 37-year-old woman who describes a change in the appearance of faces, and it causes prosopagnosia. Right. So this reading, what happens is you have to know what is Alexia without agraphia. Reading visual function is to be connected to language areas. See, they are very closely, they are connected. This is called posterior heteromodal association areas. These connections will facilitate the reading and writing. But if there is an infarction here, a 47-year-old man with difficulty reading and a loss of vision to the right, here there is Alexia without agraphia, not able to read because the visual input from the right cerebral hemisphere is not able to reach the language areas on the left side. So there is a disconnection of the intact vision in the right hemisphere from the language areas in the left hemisphere. So he's not able to read, but he's able to write. That brings us to the visual attention, which is a very important concept in neurology. The attention of the visual fields, which are divided into right and left visual fields. The left hemisphere can shift visual attention to any place in the right visual field. That's the limitation of the left cerebral hemisphere, which is a dominant hemisphere as far as language is concerned. But for visual attention, its capacity is limited. Whereas the right hemisphere can shift attention anywhere in the left visual field, but on addition, it can do so in the right visual field also. So right hemisphere specialization for bilateral shifts in the attention. So this, if there is a tumor in the right side and the problem comes, it is not at all visible. No. Yeah. Hmm. Yeah, I have a class. I'll come. Okay. Hemisphere is responsible, right? So this will cause confusion and lot of confusion and neglect. If you see how do you test the neglect, you ask them to cross these lines, and because of the neglect, he will only cross on the right side. His diagram is incomplete on the left side, right side is okay. So that's how this attention will affect in this case of right parietal ICH. So anosognosia for hemiplegia is in a right MCS stroke. Anosognosia means lack of knowledge about the disease, and some another term is called anosodiaphoria, lack of caring about the disease. He doesn't know what disease is there, so that means he doesn't know that some function in the left hand and left leg is not there. So what happens is when a patient with neglect tries to clap. Hello. Yeah. Sir, मैं क्लास में हूँ. हाँ बता दो. Thank you, sir. हाँ. So what happens when a patient with neglect tries to clap? Oh, no. This is one of the intelligent questions a 11th class student asked his teacher in a neglect case. What happens? So they didn't know, and they rang up the Harvard Medical School and the neurologist also. They never thought about it. Okay, what's going to happen if a person with a neglect is asked to clap? And then they conducted a study in their neurology patients, and they found that the individual tries to clap with one hand only. That's how it has become East Chester clapping sign, a novel test of parietal neglect. So anosognosia is detected by asking the patient to clap and find out. That brings us to another visual processing thing, like the occipital lobe, that is Bellnet syndrome, which is simultanagnosia, inability to perceive global elements, can't see the forest for the trees. And I'll show you a cookie diagram where if you are asked to describe, they will not be able to describe. And it has got another two components. One is optic ataxia, that is poor reaching under visual guidance, and poor visual search for objects is ocular ataxia, apraxia. So ocular apraxia, optic ataxia, simultanagnosia, this is a Bellnet syndrome, which is again seen in occipital lobe infarction. This is what I am trying to say, that if you ask them to explain the whole picture, they will not be able to explain. They'll only focus on particular areas, and there is, because there is a bilateral parietal damage here. So that brings us to praxis, a coordinated motor programs, and every time all the motor programs are stored in the brain, and you have to tap, and you don't have to practice every time. And this is concentrated on the left side parietal lobe and the parietal area, the praxis area. Whenever a program is to be released, and the message goes to supplementary motor area on the same side as well as to the contralateral side. From supplementary motor area, when the stimulus reaches, it sends commands to the precentral gyrus, where the motor commands are executed through the pyramidal tracts down to the final common pathway of the anterior horn cell. So if there is a problem in any of these, the learned motor acts get disturbed. There will be clumsiness in the hands. So that's what is the apraxia. Well, simply understanding that, that brings us to what is motor homunculus. There's a precentral gyrus. You have see the representation of the thigh and the leg is maximum, and as the thumb is maximum, the trunk is very minimal. Again, the face is maximum. So whenever you have a infarction in the watershed area between anterior cerebral artery territory and the middle cerebral artery territory, you can get a man in a barrel syndrome where proximal arm weakness is more than the anywhere else. The arms cannot be moving. So otherwise, typically in middle cerebral artery, what happens is contralateral face arm is involved more than the leg. The anterior cerebral artery, as you see here, the leg is more than the arm. So the representation is on the contralateral side in the brain, and this picture of man in barrel we may come across sometimes. So sensory system, the processing of sensory information, usually the crude senses reach the thalamus, but beyond thalamus, the third order neuron gets the sensations of pinprick, pain, temperature, vibration, proprioception, everything into the post-central gyrus of parietal cortex, where lot of memories are stored in the surrounding unimodal percepts and multimodal percepts, and these are used to process the sensory information. And if that function is done properly or not can be tested by 2-point discrimination test, graphesthesia test, and stereognosis test, which is a very important assessment of cortical sensory function, which which is depicted in the diagram here. The central seventh nerve palsy and peripheral seventh nerve palsy are often distinguished by the difference in the involvement of the face. The central seventh lower facial weakness is more marked without frontalis weakness because the frontalis muscle has bilateral representation. The peripheral nerve has got both. If you look at this, the motor area comes down and controls the facial nucleus. Similarly, limbic areas also control the facial nucleus. So if there is damage only on the motor cortex, but limbic area connections are intact, the emotional smile is preserved in this case. Emotional smile. You see, normally if you ask him to smile, it may not. But whatever pleases this individual with stroke and the facial palsy, they may develop emotionally normal smile. That's because of the dual connections, which important aspect of the this. So that finishes our discussion about the brain. We'll go on to the brainstem, which is brainstem is what it's doing is it's getting peripheral sensory inputs to spinothalamic tract and lemniscal pathways, medial lemniscus, and so many trigeminal tract to the brain. Similarly, it is connecting the nuclei of the ocular muscles through medial longitudinal fasciculus, and also it is conducting motor pathways from cerebral cortex to the spinal cord. So it is a highway, and there are houses. These are called, if you look them as a cranial nerve nuclei in the brainstem, and in the brainstem that 3 to 12 nuclei are present. So if there is a damage to the this house, and it's invariably the tract is also affected. So one way to identify the brainstem involvement is crossed affliction of a cranial nerve along with weakness. The crossed hemiplegias are a characteristic of brainstem dysfunction, and there is a rule of this brainstem is a home of nuclei of cranial nerves that project axons through cranial nerves 3 and 12. So there is a transmission of information, as I said, between cortex and the spinal cord. This transmission of information between the cortex and cerebellum, and also between cranial nerves. So it's a relay station. Mostly brainstem is a relay station. There are 4 cranial nerves exclusively in the medulla, that is 9 to 12. And as you see, they are controlling uh, the parts in the oral cavity and the pharynx. So the dysfunction of these cranial nerves will give rise to dysarthria, dysphasia, dysphonia. Similarly, there are 4 cranial nerves primarily in the pons. These are 5 motor, 6 cranial 6, 7, and 8. So you get vertigo, facial weakness, facial numbness, etc. in this 4 years. No voice? Why? Oh, I'm sorry. Since when? Is it okay now? Okay, right. So there are four rule which you should be able to understand. Are you able to hear now?
Yes, sir.
Yeah, okay, good. So now we develop our further discussion on the 4-4-4 rule. Vertical plane means midbrain, pons, and medulla. Vertical plane. We can localize the lesion by the cranial nerve nuclei or the axons that are affected. With the exception of the fourth cranial nerve, the lesion is ipsilateral to the cranial nerve deficit because the fourth cranial nerve, after origin, it crosses to the other side to supply the superior oblique muscle on the other side. So that is not affected. And this is the thing which I was telling you. These are the busy tracts which are going through the brainstem. It has got a motor connections, visceral sensory on the, I just depicted on the left side, motor on the right side, only for understanding sake. So a lot of 3, 4, 5, 6, 7, and all the cranial nerve nuclei are present in the brainstem. And 4-4-4 rule is told that localized in the transverse plane by long tracts that are affected. If you look at the brainstem morphology, the corticospinal tract is ventrally placed and slightly medially placed. The spinothalamic tract, descending first order sympathetic neurons, and the cerebellar peduncles are dorsal and laterally placed. With the exception of the caudal medulla for proprioception vibration, the lesion will be contralateral to the hemiparesis or hemisensory deficit. Look at this. This is a dorsal and this is a ventral corticospinal tract and medial lemniscus. This is the spinothalamic tract, and these are the reticular formation which the bottom up which we were discussing. The cranial nerve 7th, 9th, and 10th here. So the cranial nuclei are placed dorsally. The motor are placed ventrally. One important aspect we should know is from the nuclei, the fascicles come through the parenchyma and exit. That is cranial 3, 4, 6, and 12. So it is difficult for us to say whether it is lower motor neuron or nuclear lesion because fascicular lesions also will there. So there are some sensory which can help. That is a special sensory of eighth nerve and fifth nerve can sometimes help. Otherwise, the motor parts are very difficult because the motor cranial nerves, the fascicles pass through the brain parenchyma. Pure sensory cranial nerves, 5, no, not 5, 8 is dorsal and lateral in the brainstem. That is sensory part of the 5. The motor cranial environment can be challenging to localize in the ventral to dorsal plane because the reason I mentioned to you. Most of the motor cranial nuclei are dorsal and medial, but their axons travel ventrally to exit, except for the fourth cranial nerve. So this is only again to show that the importance of knowing that the fascicles run through the parenchyma and exit ventrally. That is the motor part. So look at the midbrain now. The midbrain is got the morphology. You see, you have to learn this diagram of the midbrain. You see crus cerebri, substantia nigra, red nucleus, ascending trigeminal tract, the medial lemniscus here, oculomotor nucleus is, and aqueduct is situated here. This is called anteromedial midbrain, anterolateral midbrain, and C lateral midbrain, the dorsal. So now the picture is no, this is reversed here when we compare to the previous picture. So the disturbances that are observed in midbrain problems because it's controlling various tracts that are passing through to the brain from cerebellum, gait ataxia, limb ataxia, dysarthria, sensory symptoms, third cranial nerve. So 4-4-4. Midbrain also has 4 cranial, 4 bumps. That is superior caliculi and inferior colliculi. The superior one are related to vision and inferior related to audition. So there is a third nerve palsy and hemiparesis in this case. So you can see the MRI picture on the midbrain lesions. So at times, it can, very small things can be observed and you will have to have enough knowledge. So in the following 4 diagrams, identify the structures. So these are the A, B, C, and D. I'll show you each one. So this is the midbrain. Identify the structures. So I told you the midbrain. You have to learn midbrain, pons, and medulla. And what is the structure that is involved in this place? What is structure? Anybody is willing to answer this?
Third now and corticospinal tract. Hello.
No takers?
Sir, hello.
This is the midbrain structure. So if you concentrate on 4 diagrams, you can learn the midbrain now. Since so midbrain, identify, yes, that's nice. Third nerve and right. All right, very good. So that is perforators. This is a Weber syndrome. Contralateral hemiparesis due to cerebral peduncle involvement. Ipsilateral cranial nerve 3, that is fascicles of cranial nerve 3. Ipsilateral pupillary reflex and dilated pupil. So this is a Weber syndrome. This is due to the PCA perforators which are coming from the basilar artery. This is a Weber syndrome, crossed hemiparesis with third nerve palsy. Second, next, what are the structures involved here? In the midbrain, we are still in the midbrain. So if you can take this diagram mentally and remember things. You already identified the fascicles of the third nerve and also the CST. Yeah, that's nice. Somebody's answering. Third nerve, red nucleus. Excellent. So midbrain tegmentum, tectum and tegmentum. The tectum is the posterior part, tegmentum is ipsilateral. Third nerve palsy with dilated pupil, contralateral involuntary movements because of involvement of red nucleus as well as subthalamic nucleus. And so this is a maximum of a this is a red nucleus involvement which will give rise to rubral tremor in Benedict syndrome. So third, what are the structures that are involved? So you will learn 2 syndromes now. Benedict's, Weber's. The third, yes. Reticular activating system. Oh, so midbrain, again the tegmentum clot syndrome. It's here contralateral hemiataxia. Midbrain tegmentum dorsally, ipsilateral cranial nerve 3, that is our fascicles are involved. Contralateral ataxia and dysmetric involvement of dentato-thalamo-fibers in the superior cerebellar peduncle. See, dentato-rubro-thalamocortical tract takes the impulses from cerebellum to the cortex, and you have contralateral tremor also. So ataxia, hemiataxia contralateral with tremor is Claude syndrome. Next, midbrain, identify the structures and what type of problems you have on the other side contralaterally. So identification of the brainstem syndromes is crossed hemiparesis. Here you have ipsilateral third nerve palsy because of fascicles and contralateral hemiataxia only. Red nucleus is not that much. This is called Nathaniel syndrome. So there are 4 things which I showed you. The 4 diagrams you keep in mind. You can remember this. Next we'll go to pons. Here, if there is any disturbance, you can have coma, quadriparesis, sensory loss, gaze palsies, and locked-in syndrome. So this is the MRI picture of the pons. This is the pons area in the MRI, and there is a blood supply of the basilar artery it supplies, and which is blocked here, which can give rise to various problems in the pons. And so you'll have ataxic four rule, and corticospinal tract is ventral or anteriorly placed, and the abducens nucleus is posteriorly placed near the aqueduct, and the medial lemniscus is present slightly anterior to the nuclei, and the laterally spinothalamic tract is placed. And if there is an infarction, it can cause damage like this. And if this can affect the medial longitudinal fasciculus to cause the internuclear ophthalmoplegia. Now study the four diagrams and identify the structures affected. E, F, G, H. I'll show you one after the. So what are the structures affected here in the pons, Pontine?
Corticospinal tract.
What nerve? This is what nerve? What are the
Sixth and seventh.
Yeah, that's correct. Very nice.
And corticospinal
No
tract.
voice again. Oh God, I don't know why the voice is going. I'm so sorry, but now you tell me, identify the structures.
So it
Identify
is sixth nerve, fascicle, seventh nerve, fascicle, and
Can you
corticospinal
with
tract.
this? This is Millet-Gubler syndrome. Basilar artery perforations, median and paramedian perforators are involved here. So you have ipsilateral seventh nerve palsy, ipsilateral abducens nerve palsy, and contralateral hemiparesis because of the corticospinal tract in the basis point. This is a Millet-Gubler syndrome, which is a very nice 6, 7 on CST. Excellent. That's very nice. Identify the structures now in this. What all you are seeing? The genu is very visible. That is nuclear lesion of the sixth nerve. The seventh nerve lesion is also visible. The corticospinal tract is also visible. And what is this? What is this? Yes, very nice. Reticular activating system. Okay. Right. Ipsilateral seventh, there is no doubt. And nucleus or fascicles are involved. Abducens palsy, contralateral hemi. So this is the what you said is correct. There may be unilateral affliction, so no loss of consciousness. If large area is involved, then you can have reticular activating system problems. Identify the structure. It's only CST. That is corticospinal tract, basilar artery paramedian perforators, the sixth nerve, ipsilateral, and contralateral hemiparesis. So now identify the structures in pons. Okay, so these are cerebellar ataxia because corticopontocerebellar fibers. See, cerebellum is connected to cortex by dentatorubrothalamocortical tract, which is a crossed tract, and corticopontocerebellar tract, which is again crossed. So it is coming back to the same cerebellar hemisphere. So you have ipsilateral cerebellar ataxia, contralateral hemiparesis because of corticospinal tract in the basis pontis, and contralateral impairment of pain and temperature sensation because of the involvement of the lemniscal pathways. So these are the Pontine syndromes: ventral medial pons, Raymond syndrome, ipsilateral abduction palsy, gaze palsy, contralateral hemiparesis, and ipsilateral seventh palsy. So with these things will help us in identifying or localization of this. That brings us to the medulla. Medulla is also the, if you look at the ventrally corticospinal tract, ascending a trigeminal thalamic, that means the tract of trigeminal nerve, and spinothalamic tract is laterally placed, and inferior cerebellar peduncle is dorsally placed and laterally placed, and the sensory nuclei are present dorsally, and nucleus ambiguous is present here. So this is a broad anatomy of the cerebellum, and you can have lesions and corresponding body representations like this crossed facial numbness and facial sensory loss, contralateral sensory disturbances, and at times you can have mixed ones also. So this is the medulla, the pyramidal tract, and we have already seen nucleus ambiguous, and we can read more and more about the anatomy of the medulla, and you can identify the lesions in the MRI by looking at the regional anatomy on MRI, and you see what are the afflictions: ventromedial, the ventral and bilateral afflictions, ventromedular 42%. So there are various studies have identified where the areas are getting affected, which area is getting affected. You see the medial lemniscus is bang on the midline. So there may be possible to have isolated giddiness as an ataxia in cases of stroke of the brain stem because of the involvement. You can see the dot-like hyperintensity in the brain, which can give rise to ataxia. So study the following with two diagrams and identify the structures which are involved. And one is this diagram. Tell me the structures which are involved. Yeah, that's good. One answer I got. Yes. Medial longitudinal fasciculus. Uh, CST. Okay. Right. Fine. So it's obvious. This is the pyramid. A lateral Wallenberg here. It's so we go on to the other side. All right. Medial medulla and vertebral artery perforators and contralateral hemiparesis because of the pyramid, contralateral decrease in vibration and proprioception because of the lemniscal pathways, and ipsilateral 12th nerve palsy. So that is designed. So identify these medulla and structures which are involved here. Of course, you have already said, I think, 12th grade. That's good. You picked up very well. And here you have picked up the 12th nerve. Now, see, medulla, identify structures here. And what is this? Yes. Wallenberg syndrome, excellent. So this is Wallenberg syndrome. And that is lateral medulla and posterior inferior cerebellar artery. Ipsilateral hemiataxia because of inferior cerebellar peduncle, which is dorsally placed. Dysphasia, hoarseness, ipsilateral palatal weakness because of nucleus ambiguous. Horner syndrome because of the sympathetic fibers involvement. Decrease in pain and temperature sensations, spinal tract and nucleus of cranial nerve 5 on the lateral spinothalamic tract on the ipsilateral portion of the face and contralateral body. So this is a Wallenberg syndrome. So in this, all the lesions we have considered, we consider the big picture of the brain, the arousal and awareness, the frontal syndromes, the memory circuits, the language, the vision, the spatial attention, the motor homunculus, which was shown, and the somatosensory processing in the main brain. And also, we told you that 4 principle of the cranial nerves and the brainstem functions in the midbrain, the pons, and the medulla, and the localization principles, ventral and dorsal localizations, which you see, we emphasize the role of the fascicular involvement, and also this thing we didn't next class we can stress on this. The superior orbital fissure also we didn't touch much, but this diagram we have discussed, and we'll come back to this skew deviation in the next class. And that, somebody is asking some question. Wallenberg syndrome, vestibular nucleus, trigeminal nerve nucleus. Excellent. That's nice. So with this, we have finished the applied anatomy of the brain. Next time, what I'm going to do is we'll have some case discussions based on these anatomical details. So there were about 7 cases, about 15 minutes time, and another 15 minutes we'll do the spinal cord anatomy and only applied anatomy part of it. Then we'll discuss the CNS case sheet for it. So this class is the beginning of the residency program. That's why we have taken this class again. Okay then, right. Bye.